But the other thing that we've not done, as far as I've been able to find in the research, is that we've never gone back to patients and said, hey, the ER nurse who looked after you is really interested. Is it okay if we tell them that you are being discharged home, that you are going back to work? Because we have this assumption that privacy and confidentiality means we can't share anything, but we're not actually involving the person who gets to make that choice, which is the patient.
Yeah.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
Everybody, Kevin McFarland here from the Art of Emergency Nursing, and thanks as always for downloading this episode, and thanks for listening to the podcast. If you download this in real time, this episode is going to be released on Emergency Nursing Day. So happy Emergency Nursing Day to you. Hopefully you have a great day today, and hopefully your hospital is celebrating all the amazing work that you do as an ER nurse. Your communities thank you, your hospitals thank you, and I thank you. I really appreciate what you do because I know how hard it is to do what you do. Now, I have a great episode for you today where one of the things you're going to get a chance to do is participate in some emergency nursing research. Now, we don't always get a chance to help guide clinical practice, but this is your chance. This is your opportunity to do just that. In this episode, you're going to hear about a research project that my friend Rebecca is doing. In this episode, you're going to hear all about what exactly that survey is about and why exactly you'd want to get involved. So buckle up, sit down, listen, and enjoy. You're going to love this episode with my friend Rebecca. I'm going to put a link in the show notes to her survey so that you can get to it. So tell me about yourself. Are you an ER nurse down in Australia? Or?
Yes, I definitely am. So I've spent 13 years in ED now. I did my new graduate program on gastrosurge and loved it. I was so amazed at what we can pull apart from a human body, put it all back together, and then people still eat and go to the bathroom and everything works again.
Kind of great.
What did work for me though is the palliative care aspect. I really struggled with getting to know someone's family and then watching them go through the grief process. And I found that really, really hard. And so after my new grad, I was like, where can I go that I'm not going to have to deal with this? And I was like, I'll go to ED just for a little bit and just see what it's like. I went down for a 3-month secondment and I've been there 13 years.
Like, I'll just try it out and see what I think.
Yeah,
Then there you are.
evidently I adore it.
Yeah, obviously it's worked for you.
Yeah.
Let's talk a little bit about your research. So you're doing some research specifically towards emergency nursing, and we're going to do this podcast and talk a little bit about it so that we can get some information out to the people who you want to participate. One thing before we get started, I'll just tell you is that everything's editable, right? I'll take this when we're all done. I'll edit it. I'll make you sound smart, make me sound smart, and then release it to the masses from then.
Can you just record my whole PhD and do that for me as well?
Wouldn't that be easy? Wouldn't that, if you could just record the whole thing, just be done with it?
I could just record everything I know so far, send it over to you. You make me sound smart. I acknowledge you in my PhD, academic acknowledgement's really important. I'll put you in there.
I'm telling you. I got cited in somebody's PhD paper just recently. They cited 2 of the podcast episodes, and I was like, how cool is that? Like,
Yeah.
I was like, that's
Yeah.
kind of cool, considering that, when I first came up with this podcast, it was just an idea to just get on and talk crap about emergency nursing with my friends. So I was like, that's kind of cool. So
So in my other work, I'm also a lecturer for undergraduate students in nursing here in Canberra. And I'm quite at odds with some of my colleagues who don't allow students to use things like TikTok um, as academic resources for their assignments. I literally have a little Padlet that's open to students, and I'm like, these are the accounts I follow, and this is why. And I think we really need to get on board with technology and the way it moves, and the way that learners are engaging with content now is not through textbooks, and it's not through traditional methods. It's podcasts, it's on the go, it's short little snippets.
Yep.
and we need to be on board with it.
It's gonna be really interesting to see what AI does to the future of both teaching and learning, because like everything's there. Like you type it in and you can just get it just like that. And I mean, you know, it's easy to use it to spell check, to fact check, to get citations for the stuff that you're doing. Um, it's amazing. Now it's not always right. I mean, it's still got a long ways to go. Um, I've played with it a little bit and come up with some pretty nonsense answers that I was like, I don't think that's it. So, um,
It's definitely gonna make teaching a very different space, but I'm looking forward to that. I'm actually looking forward to how do I engage with this technology and how do I help students to use it in a really clever way while still maintaining that critical thinking that we're looking for.
100%, 100%. And that's, one of the things I had when I was going to nursing school. One of my instructors was like, she's like, for some of my tests, they're going to be open book because like you have resources that you're never, you know, focusing on memorization is not the key to success and being able to provide good patient care. She's like, yeah, you got a
It's one
time
of
here.
the
You'll have a time limit. You'll have a hard time limit. You'll have to, really make sure that you're checking your facts. But she's like, I don't care if it's open book. Like,
And that's one of the challenges, I think. I don't necessarily always agree with the way that we assess undergraduate students in terms of time limits and, exams and stuff like that. Because I'm like, in the real world, when you are nursing, if you don't know something, you go ask someone. If you're
mhm,
not sure if your drug calculation is correct, you're going to go ask someone
yep.
and you're going to be like, hey, this is what I've got. Can you check it? So, yeah, I'm, yeah,
Yeah,
it's an interesting space to work in.
I always tell people nursing is a team sport. Like no one's got it all figured out. So,
And we're always learning.
for sure.
Always.
So let's start off by first introducing yourself. Tell the audience who you are, where you're from, what you're doing as far as your PhD and stuff. And then let's talk just a little bit about your research and what exactly your PhD research is all about.
Yeah. Thank you so much for the opportunity to share my little project, which just seems to have grown and grown. So my name's Caulfield. I am an emergency nurse from Canberra, Australia. I've been an emergency nurse for 13 years now, and probably about 5 years ago now, I looked after a child who had a critical head injury, and that child was choppered out of our facility up to Sydney, and it was a real turning point for me. I dreamt about this little child.
Wow.
Um, I vomited when I got to the car park at work because I was terrified I was going to see this same thing again. And there were a couple of things probably. This was a critical injury. I'd only been in resus a couple of weeks when this
Ooh,
happened. She was a single mum. I was a single mum. There were just these things that kind of related that I thought there, but for the grace of God go I, because this was an absolute accident that had happened to this child. But I was fairly convinced that this child was not going to survive the injury. And so it really impacted the way that I nursed in the weeks afterwards. And I actually took some time off. And when I came back, I didn't want to work in resus. I didn't want to work in peds. And it really impacted me for probably 4 or 5 months to the point that I actually started seeing a psychologist and working through what had happened. Fast forward a little bit, and I was then working as an educator, and I was in resus orientating another staff member. And the same crew who brought that little person in arrived with an adult patient who subsequently passed away. And I said to them, reminds me of, and I said this kid's name. And the doctor actually looked at me and he's like, you don't know, do you? And I was like, no, what? And he's like, he survived. And for reference, this child had brain on view
wow.
and he survived.
What'd you say?
Um,
Brain on view? Is that what you said?
yes,
What does that mean?
yes. Like
That's,
I could see brain matter.
wow. Okay. That's what I
Yeah.
thought. That's what I thought it meant. But that was like one of those Australian things. I was like, wait, I'm not sure. Uh, Holy cow! Exposed brain, and he still survived.
Survived. Yeah.
Mm. Now,
And
I think a lot of nurses have been there, where they've had cases that they couldn't shake, couldn't forget. And yeah, the amount of potential for PTSD we have is just crazy.
And I don't know about in the States, but here in Australia, and where I work, our ambulance service has a set criteria. And if a case meets this criteria, you will get a debrief. Our
Mhm.
police service has a criteria. If it comes into one of these things, you get a debrief. And you actually can't go to work until you've been debriefed and until your psychological safety has been assessed. ED nurses see this, and then you might take a patient to the morgue, to the theatre, to ICU, or to a helicopter to take them somewhere else. And you know what? You come back in that door, you wash your hands, you do your PPE, and you
Right
start
back in.
again. And it's just not good enough. It's just not good enough. So, yeah, I found out this little boy had survived his injuries, which was absolutely astounding to me. And
Right?
I feel what it sort of struck a chord, and I was like, what would happen? What would my life have looked like professionally and personally if I'd known that? If I'd known a month, 2 months down the road that this
You're
child
still
had
okay.
survived the injury, what would my mental health have looked like and how might that be different?
A- And
And so,
and
yeah, my little baby was born. My little baby project was born, and I did some postgrad study, and I did it as a mini research project. And then a colleague of mine said, "This is a PhD. You need to think big. This is a PhD." And so I started down the road, and everybody at that initial stage was like, "You need to do a literature review. You need to see what's out there." And I was like, "Yep, yep, totally get that. There's nothing." No, no, no. You need to go to all of the sources. You need to use a librarian and you need to look. I'm like, "I've done that. There's nothing." And we talk about PTSD in nurses in terms of the volume of patients, the acuity of patients, occupational violence, lack of resources. We don't identify ambiguity in the literature as being something that contributes to our occupational distress.
mm,
And so, yeah, it was like, oh, this is actually a gap in knowledge and let's do something about it.
and
So,
it happens all the time. I always joke that as an ER nurse, as an ED nurse, I'm like the master of short-term relationships. I'm there for a little while and I send them off and something else happens and other things are happening. It's not going to be my problem. And you see patients, and then there's always those patients that just touch your heart just a little bit more than the others. And, maybe if you're lucky and they're in your same organization, you can maybe go up and see them. But like in my organization, our sickest of our sick, we send out too. Like the sickest of the sick are whether they're traumas or super critical medicals. We may be shipping them out as well. And oftentimes I've wondered, what happened to them? How are they doing?
yeah. Yep. And so from my initial research, we kind of looked at it in terms of there are these two branches. One is that you've connected with that person or their family on a personal level because they look like your aunt or they have a story that sounds similar to something your family's been through.
Yep.
But the other branch of wondering is all about decision making and clinical care. And for nurses who work in specialist areas where they might be making decisions about medications, about transportation, when do I send this person out? When do I get more help? I decided to do this pathway. Was that right? When we don't feed back to them what happened, there's not that opportunity for learning. There's not that opportunity for critical reflection. And so the next person, someone with that same presentation arrives, that nurse has still got that ambiguity. They don't know if the decision they made last time was right or not. So we see it both impacting professional and personal lives of nurses
Right.
because there's this amazing opportunity for education and for closing that loop of communication that we are just missing.
I agree. We see it in the emergency department. We see it from the pre-hospital folks, where the pre-hospital folks will often ask us, "Hey, what happened to so and so?" And then we can give them at least, "Hey, here's a little bit of an update." But we may not be able to give them the full update. And be like, "Hey, the full." It may take a while for that full story to unfold.
Yep, absolutely. Absolutely. And so what I think, my PhD is about proving this is a problem and then thinking about how to fix it. Um, and a lot of the stuff that's kind of come up from an organizational perspective is around privacy and confidentiality. And
Yep.
I think we're missing two things here. One is the nurse who looked after that patient in ED is not asking for how many milligrams of metoprolol this person was discharged on. They want to know, did they survive? Did they get back to their pre-hospital state? What's their quality of life like? We
Yeah.
don't want the ins and outs. We don't want every single detail. But the other thing that we've not done, as far as I've been able to find in the research, is that we've never gone back to patients and said, hey, the ER nurse who looked after you is really interested. Is it okay if we tell them that you are being discharged home, that you are going back to work? Because we have this assumption that privacy and confidentiality means we can't share anything, but we're not actually involving the person who gets to make that choice, which is the patient.
Yeah. It's a good point. It's a good point because they may be very, very few patients do come back and seek you out. Not very many do, but I'm sure we make a significant impression on these people. I'm sure they remember us. They maybe not don't just come and reach out. This would be a really cool way to it'd be really cool if there was a mechanism for being able to say, hey, here's just some follow-up.
Yeah. Here at the hospital that I work at, we have a trauma service, and our trauma service will follow patients right from ED to discharge and beyond. And I know that there are patients that have been with the service 5 or more years, and sometimes it's just a yearly check-in with them, and it's an update on how they're going, and that's really useful in terms of data collection and all those sorts of things. But that continuity of care, I think, is great for clinicians, but I think it's great for the patient as well, because we talk about person-centered care, and that looks very different in the ED. And
Mm.
I'm not sure that patients understand that we actually care. This sort of perception of, oh, EDs, we've got dark humor and we joke about everything and we don't really care and we're just moving through the numbers. All of those sorts of things are actually self-protective mechanisms.
100%.
And I'm not sure that we really explore that really well with patients to say, we actually care about you.
Yeah, 100%. I think we all that is true, right? Like we do have a little bit of a dark sense of humor. We are sometimes maybe a little bit callous. Um, but we wouldn't do this. We wouldn't work at this hard job if we didn't actually care about people. It's I mean, you just can't be a nurse and not care about people. Like you're just not going to be a good nurse. You're not going to be happy.
Aren't we all in it for the money? Like the
Yeah,
amazing.
I keep saying I am, and I just keep waiting for that money to roll in. It's
It's like, yeah, no one does this job for the money. No one does this job for the conditions because, night shift is rubbish. We do this because we really care so much about patients and we want to do the best that we can.
absolutely, absolutely.
Yeah. So that's kind of where my research started. And so we started with a literature review, which identified occupational distress as a kind of umbrella term that took in things like secondary traumatic stress, acute stress disorder, PTSD, vicarious trauma. And we sort of said, well, we know these things happen, but what happens before that? And so we came to three kind of broad themes. So one is around individual impacts. So that's the relatability. How much does your life look like that person's life? Um, and that's really clinician dependent. We looked at things like the social factors for nurses on how they relate, the relatability. We looked at things like organizational impacts. So, one of the really interesting ones that we found was spectators to the work. And so, for a US example, there were some nurses who were involved in a school shooting. And so, their occupational distress was closely linked to media, and they weren't able to escape the experience because while they're at work, they were dealing with this horrendous event. And then away from work, they were then seeing social media, traditional media.
Yeah,
Um, and so that ability not to escape from work because they're spectators. But the other way we saw that is actually, I don't know what it's like for you guys, but here, our department can be chockers. Corridors are full, you're calling a triage cat 5 is like your broken toe, the really non-important things, but
yeah,
you'll have a list of 30, 40 patients waiting to be seen, and then you'll call a category 1, which is absolute life-threatening. And suddenly you have management, you have every human who is possibly not doing anything is in that resus room trying to have a look at what's going on.
Yep.
So we saw spectators both internal and external, um, and that adding to that pressure that nurses feel. And we also saw some stuff around scope of practice. So here in Australia, we have very strict scopes of practice about what nurses can do and what they can't. But certainly in some other areas, nurses doing things that are probably not inside their scope, but morally obliged to, because if they don't, the patient's going to die.
Yeah.
And so the juxtaposition of that you're in a role because you care and you want to save lives and you want to help people. But what happens when it goes wrong and you've acted outside of scope? What are the legal ramifications?
Yeah. And
That kind of
that could be big.
conflict.
Yep.
Yeah. And then the third one was occupational. And so these things happen to every emergency nurse. So it's things like workloads, exposure to trauma, pediatric care, occupational violence. And that last one is ambiguity. And everything else we found really great literature on, acknowledged, explored in literature, but ambiguity isn't. And so that's where we're headed.
How exciting. What a cool thing to, kind of scratch your own itch and find out something that personally affected you and try to find the answers to that. That's
And
awesome.
I think that's one of the things that I've actually enjoyed about the process is feeling like I'm not alone
Mhm. Yeah, for
and
sure.
feeling like this is, yeah, something that does happen to other people as well. And I'm not
Yep.
just some weirdo because I was impacted by this event. Lots
Yep.
of people are impacted by this not knowing.
100%. Yeah, so many people are impacted by stuff just like this probably every single day in the emergency department.
Yeah.
So, where are you in part as far as your study goes now? I remember seeing some flyers on Facebook and on the internet about your study. Tell the folks, how may we be able to help as emergency nurses? How we be able to contribute to your study and to your important research?
Yeah, thank you. Thanks for the opportunity to talk about this and get this out there a bit further. So we are currently collecting quantitative data. So there's a 17 question survey that would be great if anyone feels touched or a bit of connection with this topic to come and share your views with us. We're really interested in what this experience looks like across the globe. So at the moment, we have responses from every state in Australia, a little bit from the UK, a few from the US, but really looking to broaden that to show that this isn't a geographical situation. This isn't a national thing. This is an international experience that
100%.
emergency nurses are together on.
Yeah, for sure. I think this is, no matter where you go in emergency nursing, this is going to be something that's going to probably affect you. So,
And one thing I didn't really understand, is that in Australia, all our emergency departments are attached to hospitals. So our patients will come into the ED and then they'll go up to a ward or they'll get, off to theatre or wherever they're going.
yep.
And there are some that go to different places. But in the US, you guys have standalone EDs.
Yep. The freestanding EDs, so what we call freestanding EDs, are are kind of a new thing here in the States, and they're popping up everywhere. Because what we find is the traditional emergency departments are so overwhelmed with staff that, you know, there's a few corporations that like, hey, if you can pay a, copay, or, we can tag you as a visit. And if it's, a lot of the things that come to the emergency department otherwise are kind of maybe low key, you know, triage 4s or 5s for the ESI system. Um, those could very easily be taken care of in some of those freestanding EDs, and even higher, right? Like, they can take care of just about everything in those freestanding EDs. So
Yeah.
that's really exploded in the last couple of years.
Yeah. And so then, like, how long can someone stay in a freestanding ED?
I don't even know. I mean, if they got to get admitted, I think ultimately they start looking for places. So they start looking for placement like pretty quick. They're not gonna try to keep folks there typically.
So different, because obviously here in Australia, everybody has free healthcare. So the like whole copay and insurance and stuff is just such a foreign concept for us over here.
Yeah. Yeah. Oh, I mean, healthcare in the US is 100% a business, and that, for the good and the bad, right? Like there's good things about that and bad things about that. Um, it's big money business. So
I wonder if
interesting.
that introduces, so this is not related to my research, but I wonder if that sort of, whether that raises moral questions and moral difficulties for nurses. But I guess if that's the only system then that's what it
Yeah.
is.
Yeah. I think it does. And I think there's some nurses that are certainly, yeah, especially the funding of healthcare seems to be a very politically divisive thing. Like we have one party that's really like, all this should be free. And the other party is like, but no, we need to make money from this. And I see both sides. I see both sides, but so I don't know. It's a tough one.
Mm, definitely. Definitely. We are in the middle of voluntary assisted dying debates at the moment here. And yeah, I see both sides of that too. I'm like,
Yeah.
yeah, it's tricky.
Yeah. I mean, and I think we have a couple states that have that, but not many. And it's, yeah, that's certainly a hot topic as well. So,
Mm.
but very interesting.
Mm. Mm. But yeah, so sorry, back to my research. Yeah, so that's where we're at. So at the moment, we have at the to date 290 responses,
Nice.
and 98.7% of nurses have at some stage experienced ambiguity that impacted them either professionally or personally.
Wow.
So yeah, and we're really interested in the full scope. So we understand that there are some nurses who are attracted to ED because they don't know and
Mm.
because they don't get emotionally invested. And we really want to know about that as well. We're not focused just on ambiguity is a problem and
Yeah.
ambiguity is bad. We want to know that really full experience of all ends of the spectrum.
And I think that's important because there's gonna be some nurses like this just doesn't bother them. They're like, whatever, it
Yeah.
doesn't matter. They
Yes.
once the patient's gone, they're out of my brain. So
Yes. And
and I
and I
and I
wanna
think
pick those brains.
and
I wanna identify those brains to be able to go, "Tell me more about them. How does
yeah,
that work? Tell me everything."
yeah,
Um, yeah, I'm a fairly inquisitive person, so at all ends of the
that's awesome.
spectrum, how? Why? Tell me more about them.
Yeah, exactly. Well, so I'm super excited. So how many folks are you trying to get, or how long is this open that we can have people participate in your study if they choose to do so?
Yeah, so our big gold star aim is 440, so we still have a while to go. But yeah, I imagine we are going to be collecting responses for another kind of 9-ish months at this point until we reach the magic number or until I get close to submission and we have to close it.
Yeah,
So that link will work for a while yet. And one of the questions in there is if you would like to be interviewed about your experience of ambiguity. I'm moving into qualitative now and doing some interviews with nursing members of our community. So trying to dig a
nice,
bit further into what's that actual lived experience like?
nice,
How did it impact?
cool, very. How interesting! I can't wait to
Like,
see I can't wait to see how the study turns out and what you find out that people actually want and need.
hopefully ENA 2024.
That would be awesome.
Hopefully. Ho-
Hopefully,
hopefully.
be a great place to
Um,
present it.
It would be great. I'd be very happy if we could do that. I think there's also, it's an interesting topic for individuals, but I really feel that there is something there around attrition and retention and long-term longevity in our industry.
Yeah,
Um, and that cumulative effect of ambiguity, I think, and I'm trying to prove, impacts how long people stay in the job.
yeah. I mean, just in that alone, if you can save, the turnover, that's huge. That's huge.
Yep. And
So
I think organizations, and in terms of research, there's money and there's interest in the patient experience
Mhm.
and the unmet needs of patients. And, there's so much that goes into the patient experience, but underpinning that is the clinician experience. And if we
Yep.
actually did some more research on the clinician experience and how we improve that, I could hypothesize that by keeping people in the industry longer, by giving them better professional development, better professional satisfaction, we would actually see a trade off or an impact then
Mhm.
on how patients experience emergency care.
Yeah. Now in Australia, are you guys seeing a lot of turnover in your emergency departments and a lot of new grads in your emergency department? Yeah, us too.
Huge,
Us
huge.
too. Huge. It's crazy.
And it's
So
concerning.
it's
Um,
very
yeah,
concerning. Yeah,
yes.
very concerning. So, well,
One of our
cool.
hospital here one of the hospitals here has a plan for a large number of new grads to, be starting in the ED, and I think, we need to attract staff. That's one part of the story, but the other part is looking at why they're leaving and trying to mitigate that
Yep.
because, you can put things in a bucket, but if there's big holes at the bottom, you're not gonna fill the bucket.
Yeah, totally. So,
Hopefully,
well,
this
very cool.
research will kind of put a mesh stopper on one of the holes
Oh,
is kind of a
it's a
hope.
great, yeah, it's a great thought. Certainly. So, very cool. Well, how can folks participate? So I'll have you send me a link. We'll put a link in the show notes.
Yeah,
Um,
so happy to provide links. I've got some social media posts, so if you're a social media person, feel free to post about it. And we're really snowball recruiting, so have a chat with your colleagues, ask them if they've ever wondered what happened to a patient, and if they say yes, say, "Great, I've got this study that I've heard about in Australia. Here's the link." That would be amazing. I'd be really appreciative.
Absolutely. Well, boy, I can't wait to share this with the podcast audience, and we will, see if we can drum up some folks from you from the states. Now, I mean, the audience is global, but a large number in the states. Let's see if we can't drum up some numbers for you.
That
And
would
I
be
know you've
amazing.
had some flyers on social media. I'll definitely share those in a couple of the emergency nursing groups as well.
That would be
So,
great. Yeah. It's been great to hear from Australian nurses because obviously I have an understanding of the healthcare system and staffing and all of that kind of stuff. But it's been really, really interesting to me to hear the experience of international staff and to really get that sense that we are, and I think what I'm getting from it is this twofold thing is that we are this united community and that we share these experiences and talking about them is really helpful
mhm,
and feeling that connectedness is really important. And I think we are an amazing group of humans who do this job because we absolutely love it. But we're also mums and dads and sisters and wives. And there's this cohort of people who are doing their grocery shopping on a Saturday morning with an image or a conversation stuck on repeat in their heads. And that's damaging them. And we need to do better. We need to do better for each other and for the profession generally.
good point. You're absolutely right. Cool. Well, I'm looking forward to seeing if we can drum up some folks for you. And I think this is important research that I'll certainly be participating in as well. Thank you so much for sharing it with us. I'm
Thank
looking
you for
forward to.
having me on. It's been great to obviously this is my PhD, so I think it's just the best thing ever and I could talk about it all day. So thank you for giving me another platform to share my research on.
100%. Oh, happy to.